We have a great group on. My goodness, I miss seeing everybody. All right. Let's see. It's 1:32. I'm sorry. I apologize for joining a bit late, but why don't we go ahead and get started since I'm a stickler about being on time. Welcome to the digital engagement meeting. Sadly, it's not in person, but we will do our best to push forward. We have a packed agenda again, which is great. And I just want to do a shout out to Sanjay and Anisha for doing some of the heavy lift, for bringing two speakers here presenting their digital tools for introduction into SWOG. And then we're going to have several updates from really exciting work, and then close it out with some ongoing project updates. So why don't we go ahead and start the roll, Frank?
Okay.
And if you want to just use that reminder. Okay, just reminding everybody that maintaining committee membership requires being present for 75% of the meetings that we hold. So just keep that in mind.
Okay. I've gotten most of your names from the participants list.
Yep.
Names I haven't gotten yet. Zainab, are you here?
I think I just saw Zainab join.
Ah, great. Mike Fish. Okay. Amy Geschwender.
Mm.
Okay. Joe Horn. Are you on, Joe?
Joe's just coming out of the Hope Foundation meeting, so she may be joining a bit.
Got it. Becky Johnson. Mark Lewis. Sarah Mughalian. Nima Navai. Lin Nguyen. Kanwal Raghav. Allison Rosen. Dana Sparks. I think Dana's on an NCTN call at the moment. Saad Usmani. And Mindy Wisnant. Mindy, are you on? No. Okay. I will keep an eye on the participants list as we go along.
Great. Thank you very much. All right. So I know Sanjay is on. So Sanjay is, if you will call at the last meeting, I appointed Sanjay to help lead some of our industry collaborations as well as industry introductions. And I'm going to turn the speaker to Sanjay to introduce first Reply All Health and then Survivornet. Sanjay?
Perfect. Thanks a lot. Yes. So as Don mentioned, and we'll talk about a little bit, we've been sort of trying to sort of formalize the way in which we interact with industry groups that are interested in working with our committee. And so these are the first two groups that I've had a chance to kind of talk to, and I think they have really interesting products that might be of interest to people within our committee, and also potentially take back to other committees. So the first is a Reply All Health, and Richard Bagdonas is the founder of Reply All Health. It's an SMS-based texting service that acts like a private network for patients and or their caregivers to provide updates to families and friends and have like a one-on-one communication. And so it kind of helps potentially as an opportunity to eliminate sort of the crosstalk that happens when people get updates in a clinical setting or also with family. And so it kind of simplifies exchanges between patients and others. And I don't want to go into too much detail because I know Richard will give a better discussion about it. But I'll say of note, Richard has a very interesting story about how he kind of developed this, but he's a cancer survivor himself. And so part of his sort of interest in designing this product is because of his own experience with cancer and COVID. And so, I had a chance to talk to him, and Don had a chance to talk to him as well. And I think that this is a really great company that we should, like to hear more about. So Richard, you have the floor.
Awesome, thanks. And let me make sure I can share my screen. Great, I can. Before I do though, good morning and good afternoon. My name is Richard Bagdonas. As Sanjay mentioned, I'm the CEO of Reply All Health. I want to first bring up my screen so that you can actually see and go along with the presentation that we have. Can everybody see the SWOG Cancer Research Network presentation?
Yes.
Perfect. So most importantly, I believe, is why we are here. In October of 2018, I was diagnosed with stage 4 mantle cell lymphoma and given 3 to 5 years to live. That would come about right about now had no treatment been offered to me. I had a website that my wife, after she and I had Googled ourselves into hysteria and started getting connected to the folks at MD Anderson, friends and family were reaching out to us because they heard as we started socializing it with our close friends and family. And next thing you know, there was this tidal wave of people calling and texting and emailing and Facebook messaging and Twitter messaging, and it was just a constant stream that if you've ever been through the cancer journey, is one of the most stressful things to deal with, is keeping everybody up to date. And so we tried to use a website. I posted my story on the website and kept it up to date. However, people just went once and saw it, and then they would come back to me and ask me, hey, what's going on? They'd ping my wife. It was a lot to handle, especially as we were entering in the black box that is cancer care. We were thinking about using Facebook, but that felt very public. The website felt very public. And what we needed was not a social network. We needed a private network in order to be able to communicate with folks. And so to give you the short end of the story, I was patient number 1 in the clinical trial at MD Anderson using pure immunotherapy, ibrutinib, Rituxan, and then eventually venetoclax to remove the dead cells from my body. And in 56 calendar days, I went from having stage 4 mantle cell lymphoma to being in complete metabolic remission. So congratulations to you and your colleagues for being able to provide the cancer care necessary for my family to be able to keep going, and for me to be able to participate in their journey with them. Now, after that, I was really thinking about how best for me to create a system that allowed people to communicate with their loved ones. And one of the big challenges that we had was AT&T limited me to only having 10 people on a message thread. And if you're me and you have my mother-in-law and my mom on the same message thread, they hijack it. And next thing you know, they think it's the only communication methodology they can use. And 10 people are receiving updates from them about what's going on with them making dinner and what's going on with my cousin, things of that nature. So this was really created out of my necessity to manage my own communication with friends and family. Last year in June, I was diagnosed with COVID. I was hospitalized twice, and I had the luxury of using the system that I had built. It didn't have a name at that point. It was just something that I had created, and I decided to use myself as a guinea pig while I was in the hospital. What I was able to do was send a text message to a phone number. That phone number then relayed the message individually to 155 people that were watching my COVID journey, because I was one of the first few people that anyone in my friend group knew that had COVID. And again, I was inundated with all of these calls and text and email. So that service became Reply All Health. Now, how it works is, a patient or their care partner or even a loved one signs the patient up for a Reply All number. It's a new telephone number. It's in the area code that the patient has. And the beauty of this is not only can the patient use it, the patient can identify specific people who can be administrators on their Reply All number. So that way, if the patient is in surgery and their spouse or loved one wants to update the friends and family, they can do so without having to try to log in with the credentials of the patient. The number is the starting point for this whole communication network. The patient can ask people to send the text message with the word hi to their reply all number, and they're instantly subscribed. The patient can also go onto our website and add people that they would like to. They can also identify people as part of their inner circle, because not all messages need to go to 155 people. If I want to just deal with the close family and a couple close friends, I can send something to the inner circle only. So we have inner circle or everybody, which really matches the patient journey and that I went through. Now, the patient can send a text message with photos, videos, an update of what's going on with them. And the beauty here is each subscriber to that number gets their own message. So if they reply to it, it doesn't go to everybody. It actually goes back to the system. And every day we send an email digest of what people have said, or the patient can go onto our website and see instantly what people are saying in real time. Now, one of the things that is very important to me, I've been in healthcare in the health tech space for about 18 years now, and that is security. We are not using this data in any way whatsoever. And so what happens is when a patient or their care partner sends a text or schedules a text to go out through our system, we encrypt the text, the contents of which individually, each one is uniquely encrypted, and we don't look at those. What happens is we store this data in a Microsoft data center in Azure, in the same one that GE Healthcare and a variety of other companies put their data. And then we decrypt the update in memory to send the text messages out, and then the data just remains encrypted. And then, as you can imagine, the cancer journey is a very personal journey. And so when you're done with the service, let's say you finish treatment or you're at a point where you need to close the account, we permanently delete everything in the account. So that way nothing exists afterwards. The patient has no issues surrounding their confidentiality, their privacy. As you can imagine, with 500 million Facebook accounts being hacked last year, if we were doing this on Facebook and I was a person who was a well-known celebrity, that would be detrimental to my ability to maintain privacy and discretion around my cancer journey. Now, Reply All Health is a really nice, simple point solution that can be completely customized around the brand of another company. And so if your organization is looking to use Reply All Health to help some of the patients that are going through and entering the early parts of their cancer journey, you should know we already have patients and care partners using the system. We completely eliminate the need for the patient to deal with calls, texts, tweets, direct messages, all those good things. You can update family, friends, coworkers, anyone who has interest in knowing how you're doing and can provide feedback to you, like great job on the latest chemotherapy treatment, keep going, or we're so glad you got out of the hospital. The big issue that I dealt with when I was in the hospital is the Wi-Fi sometimes is really poor. And all we're left with is a very mild and small cell signal because of the walls of the hospital. So if you have one bar on your cell phone of signal coverage, Reply All Health still works. It goes out as a 3G. If 5G is not available and 4G is not available, it goes back to the 3G network. And for those of you that are on Apple devices, sometimes your blue message goes out as green, and that indicates that it went over the 3G network because it couldn't get access to the full 4G or 5G networks. Now, I mentioned a bit about white labeling Reply All Health. We've been working with some cancer organizations who are supporting patients that don't want to go out to them with Reply All Health as the brand name. They'd like to go out with their own name, and that's where our white label solution comes into place. Your logo, your images, your text, your colors, all of the branding from start to finish looks like your organization. And your organization can determine who pays for the service. Is it the patient that pays for the service? Do they pay a portion of it? Do their care partners get involved? Does the hospital or cancer organization provide a subsidy for this? And so your organization can pay Reply All Health directly, or you can pay a portion of it, have the patient pay a portion of it, etc. So I know I've talked a lot and I've showed you a lot of text, but what I'd really like you to do is test drive it for yourself. I created a promotional code that you can use on our website. If you go to replyallhealth.com after we're done today, and in the upper right-hand corner, you click sign up. If you put in SWOG 2021, where it asks for a promotional code, we'll cover all your costs. You can see the pricing on the website. It's a very small amount to send a text message out, add a subscriber, send a photo out, view replies. And so it doesn't add a significant cost burden to the patient. And the beauty of it is, because it is consumption-based, the patient's caregivers and friends and family who want to help but don't know the best way to do so, they can actually put money into the account for the patient to help offset some of their costs. So what I'd like you to do is go to replyallhealth.com after we're done today, click on sign up, enter SWOG 2021, add some friends and family or coworkers if you're testing it within your organization, tag some of them as part of your inner circle, and then send some updates to them. And then ask them in the update, hey, reply with something nice to me. And then you can go onto the website and see what the replies are. And then when you're ready to chat about it and incorporating it into your organization, please email me. It's pretty simple. I'm richard@replyallhealth.com. Now, I know that we probably have a lot of questions that will come up here, so I'd love to take some of your questions.
So Richard, it's Don. Thank you so much. If you want to stop your screen, we can get everybody on camera as a sort of a group. So what I thought was really interesting about this tech, and I'd love to open it up to this group for some ideas because it's going to feed into what I'll talk about later. So have you used this in other ways instead of just having patients sending out the tweets? I'm thinking in the context of a SWOG study, one of our areas of ongoing interest is keeping participants updated, for example, on how a trial is doing, letting them know what the results are. Actually, one of our members here, Kathy Crew, did a beautiful paper, which I cited on a recent FDA call, about how patients want to be informed of study results, and there's such heterogeneity. But social media isn't one of the top ways they want to learn about a study, for example.
Yeah.
But having used this in other functions rather than have patients sending out the tweet, like working with an institution or a research team and saying,
Yes.
If you sign up, we'll let you know how this is going.
Yeah, that's a great question, Don. Thanks. Primarily, this was initially focused on the patient commuting outbound. However, we've had organizations say, wait a second, we have a collection of patients that we'd like to message to them. And then based on their particular interest or based on their particular situation, we'd love to know information back from them. And so organizations have been using it to communicate outbound to patients or potential patients, and even ask them questions like, would you be willing to sign up for a clinical trial using immunotherapy with a smaller amount of chemotherapy and radiation treatment? And because the patient's replies only go back to the organization, and it shows which patient was the one that replied, it's a very easy way to have a communication that doesn't cause any concerns about emailing a patient or trying to send them through a different messaging tool. Because one of the things that's important to understand is SMS text messaging is a 98% open rate. Email is, man, like 20% of that, and on the great day. So you really have an opportunity to leverage that. And Arpit, thanks for your question. We are working with the Livestrong Foundation, the Kidney Cancer Association, There's a few that are on our list of targeted organizations, including MD Anderson is piloting it at this point. So those are the types of organizations that we've initially contacted because my journey started with mantle cell lymphoma.
Questions from the group?
Actually, there was some in chat.
Yes, Jen Klump had a question as well.
Yes, so the interesting thing about Caringbridge, because Caringbridge is that public website that you can post information on and people can get updates to it, it adds a bit of friction, especially when you're dealing with the elderly. My mom is 83 years old, and every year she loses technical acumen. She's reduced her ability to work with computers and go to a website and look at that. However, she text messages with her friends and her family every day, so it's a very common way for her to do so. It also doesn't require her to have an account or her to have to go somewhere else to get the information. It just pops up natively on her phone.
Mm-hmm.
Is it connected to, sort of like Facebook or other applications? No, okay.
No, ma'am, this is completely separate. It's completely isolated. It's a private social network, basically. So that way it's a social network that the patient creates, and it's only intended to be part of their care partners, their caregivers can also be included in their friends, families, and coworkers. And they have the ability to specifically allow people to join, and they can also close it off.
What does that interface look like for the people who are organizing the site? Can they see it on their computer, or is it all phone-based?
Oh, so we allow everybody we allow the admin and the care partners to use their cell phones. They can do everything through their cell phone. However, they can also do the same things through their computer. So in this case, if we want to update friends and family, this is my phone number. That's not my cell phone number. So the beauty is I can give this cell phone number out, and it's not really my cell phone number. It's just my reply all. And I can schedule this to go out. So let's say on Saturday, I'm going to go into surgery, and I only want to send this out to my people in my inner circle. I'll be, I can say, hi, I am going into surgery this afternoon. Wish me luck. And then I'm going to schedule the update. And the beauty there is now the update is going to go out on the 16th at 1:04 p.m. And it's going to only be sent to my inner circle, and I have a chance to edit it or remove it. I can also see replies that have been sent based on the last 7 days, the last 2 weeks, the last 30 days. And you can see that I get information about what people are saying, and it says who sent it. It says what they sent. And I'm not bombarded on my cell phone when I'm trying to deal with my care team at the hospital. And then, of course, I can manage my subscribers. And so subscribers, the beauty of this, and I didn't mention this earlier, is subscribers can choose whether or not to get these updates on their cell phone as a text message, or if they want, they can get it on email. And one of the beauty of these things is when they give us their email address, we ask them, would you like to catch up on everything that's happened? So that way you're not starting fresh, but really this communication has been happening for a while. So we're able to email them all of the past messages that went out so they can catch themselves up on it. And then of course, subscribers have the ability to opt out. So, you can see who's in my inner circle right here. And if there were somebody that was subscribed, but they decided to opt out of it, this would be read with a line through it.
That's great. Cheryl Revels has a question.
Yes, ma'am.
You might be on mute. Nope. John Summers.
Hi, Richard. Very compelling software. I was wondering, have you considered adding some kind of geofencing to it for a live interaction? I know that, and perhaps you just need a larger base, but one thing that really helped when I was hospitalized as a patient was someone in the other room became like my walking buddy. And every night we would go on walks with each other. So I think it would be really cool if there's a way for people who are in a hospital that potentially don't know each other could communicate with each other and, you know, form a kind of support in that realm. But I don't know if it's going that way.
That's a really interesting one. I'll note that to see how we can explore that with our product team.
Okay. Becky, did you have another question?
Yeah, I wondered what the pricing structure is. How much would it be, for example, per month for a patient with a very active medical condition going on? And can patients sign up directly, or do they have to go through their organization?
Patients can sign up directly. If they sign up through their organization, they get a little bit different pricing structure. So let me bring up the pricing structure over here, and then I will share my screen again. 1 second. This is the website. And of course, we start the website with why. And by the way, we have about 7 more minutes, so we have plenty of time for questions because we're going to 1:05 p.m. Central. So the reply all number, if someone has a number, it's just $2 a month to keep that going. So we order a number for them and we maintain it every month. When you add a new subscriber, it's only 10 cents. So I add 100 subscribers, you know, $10. It's not a major cost for them. To send a text update, it's only 3.5 cents, and that goes out to each subscriber. You can send a photo at a nickel and receive a reply at 3.5 cents. This is our consumption-based pricing. However, we do offer through our white labeling the ability for you to set up particular plans for consumers. So your patients could be put into a plan that limits the number of people in their inner circle or in their total subscriber base. You can limit the number of messages they get to send every month, whether or not they can send photos or not. And the pricing can get down to, you know, $5-6 a month per patient. So it's very cost effective when compared to other systems. And I'll tell you that my wife and I, we had people come and talk to us after we used this that said, hey, my father is going through a cancer journey himself. Can I sign him up on this? And we haven't done any real marketing on this. It's been word of mouth and patients who have brought people in as subscribers who have then themselves become patients, because we always start life as a patient and we end life as a patient. So there's bound to be a time where we need this, especially later in life.
Anne-Marie Mercurio has a question.
So I'm just curious if you've thought about like kind of the unlimited data pricing, if I go back to like cell phone usage, because even though those numbers look small, you know, it can rapidly add up, you know, as someone that's, you know, or playing with an iPad and doing things, and it's like, yeah, I'll do this, I'll do that, and then all of a sudden my bill comes and I'm like, what the heck did I do this month? And I have to go look at all of the different things I subscribed to or articles that I read that I paid for, and I can see how in a very active situation those seemingly minuscule numbers could add up, and I'm trying to be mindful of like financial burden on patients. So love to hear your thoughts on that.
Yeah, so we have a hard cost to have a telephone number every month. When we order that number, we have a cost that we have to pay for it. Every time we send a text message out, there's a hard cost for us. So an unlimited plan is really an actuarial table for insurance, basically, where we would have to assume that, okay, an unlimited plan might mean that somebody is going to send 100 people 10 messages a month. And in that case, we can move them from a consumption-based pricing to a plan-based pricing. But there's always going to be a hard physical cost to that, because otherwise we would have to go into the idea of having everybody install a mobile app on their phone, and then they would get a notification on the mobile app, which you know, it would just reduce the number of people who would actually be able to A, put an app on their phone, B, connected to the right person, and then C, look at those every time something pops up. And I know that Peggy had just put on the chat that this would have protected a recent patient from the infighting of family members and messages as to the questions and suggestions to the patient. Boy, that is absolutely true. That's why my mom and my mother-in-law are never on the same message thread. I'm sure that we all have a situation with loved ones where they may not necessarily help the communication. And
so
then,
just to, oh, sorry, Richard, go ahead.
Oh, and then there was a question about international numbers. So for families outside the US, we currently support numbers within the US. When we go outside the US, the costs for us go up dramatically. And that's where we've gone to emailing people that are international rather than sending it to them on their cell phone. So for international folks, that's why we have the place to drop in an email address. So they still get the updates, but they do so on an email rather than on a text message.
So just briefly, Richard, I think Sanjay and I both talked to you about SWOG. So this is essentially it's a research organization, which you know, hopefully will do exactly like you benefited from as well. So we run trials nationally and then also internationally, at least participate in them. So I think looking at it at the lens is what I'm going to task this committee to do. You know, I think it's a really neat technology in terms of, you know, how can we, you know, increase accrual into clinical trials? How can we keep participants engaged? You know, and at least even for the Hope Foundation, is this a potential way that we can continue to, you know, tell everyone about what Hope Foundation does and what SWOG does in terms of a fundraising vehicle? I think it all has really interesting applications. If anyone is interested, please reach out to Richard. He's been exceptionally accommodating. But again, talk to your committees about this technology in the research side of things. And then all of us here on this call, just keep it in mind for later on in this meeting when I know Kathy L. Bain is here as well. You know, hopefully she will also comment on this a potential venue for digital tools to be studied within SWOG. So Richard, I'm going to close it there and then hand it back to Sanjay. Thank you so much for joining us.
Awesome. Thanks so much. Great to see everybody. And Sanjay has the deck should you need it. And then I appreciate all your time.
Thanks.
Thank you, Richard.
Bye-bye.
Thanks a lot, Richard. Yeah, so I do have all the decks and we're going to keep kind of compiling those as we sort of have more companies come, as we kind of mentioned last time on our call, that we're trying to sort of create sort of this organized repository of just different companies that are coming to us or organizations that are interested in sort of collaborating with us, so we can kind of make sure that we, you know, create some sort of intelligence and framework that we can kind of evaluate and compare and use those for, you know, just kind of better informing our committee. So next up, we have Steve Alperin. He's the CEO of Survivornet. I had a chance to talk to Steve about Survivornet. It's a very interesting kind of patient-facing company which focuses upon delivering sort of accurate and trustworthy content regarding cancer treatment and management. And so basically, Survivornet has a bunch of curated media that is that involves like top oncologists and expert physicians to bring information about cancer. And I feel like potentially there's some opportunity here for Survivornet to potentially help us leverage better engagement from our patients on clinical trials, which may be complicated. Because I will say that I showed some of the videos on the Survivornet website to my wife, who's not in the healthcare industry at all, and she was like, "That's like the best and most clear understanding of what you actually do," which is great. It's like 10 years into our marriage, and she finally gets it. But just, you know, so I think that there's a lot of opportunity here for our patients, and so I'll hand it over to Steve.
Thank you so much. It's really great to be here. I loved hearing Richard just now. Like, I didn't know that company and I want to talk to him to use it. So thank you for the work you do. I'd love to just tell you about Survivornet and also just an idea, kind of one tangible thing that Sanjay and I talked about. And I'll put up a little deck. Right after I graduated from college, I grew up in Philadelphia. Graduated from college, my dad was diagnosed with esophageal cancer, which, as you all know, there's been almost zero progress until literally like the last 18 months with some of the immunotherapies. Pretty educated family, I guess. I don't know. We're, somewhat pushy. My mom's an attorney. She's 89, so practices law. We didn't get to the right places. My mom went to the Cancer Treatment Center of America for 45 minutes. We finally got to places. It wasn't great. He didn't make it. The feeling of loss stayed with me, but the feeling of like, maybe as a guy, I'm still processing that anger, or I don't know, like, of not having figured it out stayed with me. And I kept meeting folks like that. Went to work at CNN. And then for about a decade, I was one of a couple people running the evening news program on the ABC television network, which at that point was Peter Jennings. A lot of people who work in our company now don't remember who that was. He died of lung cancer. His lung cancer story was impactful in encouraging another, I think it was 4 or 5% of people the next year to go get screened who'd been smokers. And I actually have been working for myself as a television producer for many years. And a few years ago, I told Sanjay, I was up at Yale actually, and we were doing hundreds of films. And I started meeting older guys who were as sick as my dad. And they were some of the first people coming off stage 3 clinical trials, with Keytruda and Opdivo. And I thought to myself, what is this? And why is the large swath of the media business and the health world, traditional legacy media, ignoring this or doesn't know about it? And my God, there's this huge gap for people when you get sick. And the basic thing is, I believe there are millions of people, and you deal with them in your practice every day, who, when you get sick, it's really hard, way too hard to figure out what to do. I don't care how much money you have. And for the indigent populations and the diverse populations, it's dramatically too hard. And as we all know, they unfortunately do worse. And so I decided to do something about it. This fundamental problem, I believe right now, Survivornet is, and every day we strive to get a lot better, really the leading effort, the most scaled effort to try to do something about the information gap in cancer. And every day we think of ourselves, we started partnering with pretty much every comprehensive cancer center in the country. We're now partnering at the community level as well, as obviously 80% of people are treated outside NCCN centers. And the goal of what we're doing is to try to help people feel less alone, empowered, with some highly structured information. I think I'll let you all decide, but many orders of magnitude, I think, deeper than you'd find on a general interest health website, not at the level of a textbook or a PubMed. And we're continuing to invest to serve people at the right time with the right information in their life. I do think it matters. Initially, it really mattered to get, an educated family with money tries to get, who's that person I have to get to. I don't think you always have to, I've got to get to that place with that, who's that key opinion leader. I do think it matters to hear their opinion, and we're trying to, I don't sort of self-satisfying to say democratizing access, but I do think as a mission-driven company, I do want to make it democratized. I do think that, the giant amount of people who don't get a genetic test on diagnosis and might benefit, the people who don't get molecular testing, people who aren't necessarily offered pathways. I see some people who do myeloma on the call, like, being treated with doublets, and the standard of care is triples and quadruplets. I get out of the bed every morning feeling that's wrong in the world. And we really try to do something about it. Every day, by offering structured information, we're trying to have people walk into the doctor. And so everyone on this call may not agree, but I want people to walk in and say, what about this? I like the what about this question. And if we do that, geez, I think I made a difference in someone's life. And if I made someone feel, hey, geez, you're a little bit less alone because you heard someone else's story, that as well. So what's different? There's a bunch of other companies out there that may do portions of this. There's the WebMDs of the world. By the way, I think number one is I try to really get up every day serving people, like everybody on this call. From day one, we're a 4-year-old company now. We've got Close the Gap. We spend a lot of time on diversity and inclusion, trying to make the content look like the audience, trying to address people's fears. It's a very fundamental part of our mission. But also fundamentally, there's some public numbers, like I don't think anybody in sort of the muscle fashion and dollars matter have gone around to initially comprehensive cancer centers of the country and been lucky enough to be given, we don't pay anybody and they don't pay us. We're an ad-supported business. By the way, I'm a business. I think that's the best way to make a model that produces excellence in what we do. And we've been lucky enough to partner with, collaborate with major institutions and community institutions in the country, some of them represented on the call. We get a big slice of cancer. We have 2.5, 3 million people a month, pushing 5 million visits. These are unique visitors. About 30% of them come back. And I guess I say the scale, well, it's like a wonderful kind of air cover in cancer. As you know, there are 1.8 million new cases a year. What really matters to us is, in ovarian cancer, the 22,000 new women, do we get to them? How many of those people do we get? Metastatic breast cancer, HER2 positive, what's our penetration? So we spend a lot of time. The big issue for us and for many people is, how do you get to cancer patients? I liked Richard's word, friction. The real issue is friction on people who are educated, let alone people in demographics that might not have as much money. And so we spend a lot of time publishing for folks who are our partners. We are regularly, every day, trying to do the practice-changing information, which, thank goodness, is at this enormous revolution. I think we're well beyond inflection point. We do stories every day. For anybody who thinks about how to reach patients' information, stories are the number one way. We've done more than 1,000 patient stories. We think of them as little short-form documentaries. And everyone loves positive stories. When we show somebody a story of someone who's just ahead of them in the journey, there's measurable anxiety relief. That's a piece of data that I stand behind. I don't do trials like you do, though we want to do one with you. But number one, if I hear someone just ahead of me in the journey and they're doing okay, or they've made a decision, very measurable anxiety relief. I might at my peril shift to our site, but what we've done, did I learn Zoom probably over the last 8 years and a half? You all seen a site that says myeloma? Is that showing up?
Yes.
What we've done is taken the NCCN guidelines and divided them up in discrete topics with some extraordinary people who have collaborated with us, so that there are very specific ways to figure out, this might be interesting for me, and what is this person who in the field, eminent, extraordinary communicator, might have to say. And we've done this across the journey of cancer. If you're on a third-line refractory myeloma, it's less interesting, induction therapy, that kind of thing. We have about 85% of cancer by incidence. We're adding more cancer all the time. That's a real big part of what we do. I'm going to try to go back to a deck and upset victory. All seeing a deck now, by the way. Does it say our platform?
Yes.
Upset victory on my Zoom techniques. Anyway, the fundamental idea of right information, right person, right time. We do guides for local physicians. That's getting data. Like, for anybody, if you hear, like in the media world now, they're doing away with these things called cookies that are basically a proxy for audience quality. How do you know that somebody's watching who we want to help? And so we get 6 minutes a page on our disease-specific content. Like, nobody watches things about KRD or VRD if you don't have it, or someone you love doesn't have it. And so, like, for us, that's a really interesting thing. As I said, these guides are done in a highly structured way, using NCCN guidelines as a starting point, and then trying to have points of difference. Places where really great people who are your colleagues, who respect one another, may have different views or different things to use first or second. And the idea is trying to arm patients with the, well, why not this, or what about this kind of question. Not everybody loves those questions in clinical practice. We think every conversation is better with an informed patient. We do these guides for physicians at the local level. There's really interesting data I have here on, if you take some cancers where you have in a markets kind of like 10 through 30, cancers like myeloma or ovarian cancer or CML, you might have a few hundred patients. And so we think that it's nice to have the extraordinary leaders in the world as you are, but you have to go ground level and try to reach people who will never have the appointment, who will never get to Comprehensive Cancer Center, and try to get them to be able to push. And as well, we think that physician education and enabling physicians with materials to educate their patients to work on issues like adherence and compliance in a lot of cancers. I first learned in New Haven, I think I told Sanjay this, maybe it sounds naive. First time someone in urology told me, a lot of my patients, we get a diagnosis, these men and prostate cancer, they don't come back. We have to call them 4 or 5 times to get them to come back because they don't feel it and they don't want to know. And so I think that there are, we try every day to try to get at those issues. You hear a lot about on our side of the table in the information business, the idea of structured data and also first party data. Everything we do, we try to say, geez, what's ethical? And my way of saying is like, if you as a patient tell us something about yourself, we'll help you. We'll try to help you. So, hey, I've just diagnosed, we'll send you 20 emails in 60 days. Reaching people at these critical points on our side of the table, as well as think about clinical trial accrual. I was on the phone this morning with a big CRO. Maybe controversial. I'm learning a little bit as I go. I'm very deep in, but certainly you also are very deep in. These critical moments of, if you get 1% more people in clinical trials, it's like the victory for the planet is mind-boggling, right? For the work that you do, just 1% more. So if we, educate people up front, it's a lot of muscle behind the curtain. Here's a little data on, if you think about local markets and real disease-specific information, the way we try to tackle information battle is getting to high volume community practices as well as comprehensive cancer centers. How we measure, is somebody really engaged and can we make a difference there? If they watch 3 pages of something around a PARP inhibitors, or you have it or someone you love has it, nobody just watches this stuff. So I didn't know a little bit exactly the format, but I'll go for it. Anyway, we have a big platform in cancer, and we're working at it every day to be better. And I think we can be better every day and need input, and I love your input. We want to test the power of information in real specific pathways. You're going in to get a procedure. I know I got one of those tests of the heart where a breath hold test, and I thought it was going to be like an x-ray. It was 50 minutes. I hyperventilated. No one told me what it was going to be like. It was the other day. I felt kind of old. The preparation in, I guess, called specific service lines, specific indications. I have a hypothesis that we can create a better patient experience and better outcomes, maybe better adherence and compliance. And I guess my pitch is, hey, geez, I love your input because how we do better around what we do. But real specifically, this is the kind of thing we'd like to study in formal ways with highly academic folks who can keep us, make sure that we do something like this that's taken seriously in the way that it is formed scientifically, and try to study whether and how information can help people get through something better, have a better outcome, stay on a particular pathway or procedure. I'm well aware, though, certainly not know that we need collaboration on the self-selection of all the issues that might play into running an authentic regression analysis of who actually would be captured in something like this. I think most importantly, I'm very grateful for the chance to introduce us and what we do and our passion. And certainly there's folks on this meeting. I think it's probably the most attended, maybe because you call roll, a webinar I've been to in quite some time. Introduce ourselves. And also this is an idea that I had for maybe collaboration, and I'll maybe stop there.
Well, Steve, congratulations on building this. It's certainly a pretty impressive website, and I totally agree with you in terms of patient stories driving information as well as understanding. I think what we know about social media, right, is that people are on there to find their tribes and their communities and to see their own experiences sort of reflected. So let me open this up to the group. You can go ahead and speak, or you can raise your hand, and I can make sure that you're chosen, and you can ask your question. Dr. Nguyen has a question in the chat. Do you have any data on the demographics of your visitors by age, sex, race, or ethnicity?
Thanks. This may not surprise you. Women. 65% of people are healthcare decision makers in their late 30s to early 60s. Women are making these decisions as a large group. Probably won't surprise you in your stuff. We track on 13% Black people of population. That's about what we're getting. About 25% caregivers. There's a certain percentage of people who are not seekers. There are 20% of people who are not going to seek new information in a diagnosis. And that's not who we're serving, unfortunately. So largely female, late 30s to early 60s. There's certainly seekers. I think I tell my mom, 90s, the new 75. I mean that in some ways. I think you have older patients who are ignored, treated badly, like they're stupid or out of it. I didn't necessarily agree with Richard. I think there's a whole new generation of older people who are consumers in healthcare. I don't know, maybe I'm biased because I love my mom, but so we try not to leave, Breast Cancer Month, it's easy to be positive and pink, and I like positive and pink. We try to put the tent where there's, older folks get left out, metastatic patients. That's kind of my direct answer on it. Someone says also, is it all video based? No. We do complementing the video, and certainly in news content every day, we do text. There's certain people, and every video has a transcript as well. The point of the video was like, hey, can I look you straight in the eye if I can never get an appointment with you? And there's some value in that. Not for everybody.
All right, Dr. Johnson has a question.
I wondered if the website has any specific stance on clinical trial enrollment. It sounds like you're trying to promote it, but I wondered if you get patient videos saying, yes, I tried this and it was great at this stage of decision making. Do you also try to get somebody who made a different choice? And how do you manage those decisions on your video content?
Thank you. I think we track to the rest of the cancer population in that the clinical trial participation accrual is small, is my candid answer. It is a major next step for us. We have partnered, just because like we're editorially independent. I take ad money like old program I used to run. It doesn't influence our content. I think it's part of next steps. We certainly try to educate people. There is very small, relative to 2.5 million people a month, it's small uptake, just so I'm not kind of BSing you. I do think we and others can do better. The answers you get when you ask clinicians are sometimes not satisfying. We have some new tools that are laying on top of clinicaltrials.gov that I think can be simpler. And I think the patient story way is the one way we've seen some success, especially in diverse audiences. So that's one, like, I think there's you all probably know this more than I do, or maybe disagree, but a lot of people come to the doctor, Black patients, am I going to be experimented? Are you going to experiment on me? And so I think we've done, I think, a better job than some, and more to go on that particular issue. Otherwise, I think we can do a lot better. If I say that we're doing great, I think that would be not a good answer.
Thank you. Anne-Marie Mercurio has a question.
So my question is, are patients that are within the population that you're trying to reach, are their voices incorporated alongside the clinical voices? Because I'm on the site on a different monitor while you're talking, and I think from a patient perspective, I don't want it to be that it's only doctor voices and it's only celebrity voices. I think this is wonderful for information, but I think that there needs to be, we need to be mindful of the person who's consuming the information. And most of us on this call know it's a razor thin line that you have to walk so that you're not turning away half of the people because of a single stupid word that turned people off. And with that, I will shut up and let you speak.
No, please. I think, look, I'm mindful of the somebody's worst day, week, or month of their life. And I think, as you, like in any kind of volume of clinical practice, we have a significant team now. And do I think that we do a good job every day? Yes. Do I think that there are times when things that are triggering slip by? I think so. By the way, the people hate the word survivor. I don't. That's why I used it. But I think people hate the word fighter and battler. I hear you. We've done, I think it's 1,250 short form documentaries. It skews to regular folks. And so in each of our sections, there's living with cancer. And then largely what we do in, let's say, the acquisition of patients is story-based on Facebook, where you get the female decision maker still. Facebook's having its issues, but it's still very good for us. In organic, and also for anyone that's doing this stuff, the little bits of targeting we do on a paid story, like with regular folks, there is value. There is that. I'll say in myeloma, like Tom Brokaw, 5,000-6,000 people a month come, want to know why Tom's alive. He's on Revlimid. You know, I did my story on this guy used to be famous called Peter Jennings. People knew. I think there's a place for that as part of the quiver, not the quiver.
Yeah,
kind of my deal on it, and I think you bring up a good point.
Yeah, I think it's an interesting question of and certainly something that, you know, as a clinician, I've often asked myself as well, whether or not finding your community or seeing your story or sharing your story, how does that impact on outcomes? Certainly, novel ones could be tested on a clinical trial. Say if you were part of SurvivorNet compared to someone who wasn't on SurvivorNet. Did you stay on the study longer? You know, for example, or was it more likely that you were not going to stay in the study? You could look at side effect profiles on a clinical trial by embedding in a community like this in a more formalized way. You know, so I think it's a really interesting question that could potentially be tested, but I'm wondering what other people think. We have a couple more minutes. And I will start calling on people if you do not start responding. Dr. Gunturo, you can start.
Sorry, Don. I was just tweeting our digital engagement on the Twitter, so I apologize.
No, but it is an interesting one. You know, you're designing a clinical trial, look at IO toxicities, which I think is, we'll talk about that later on as well, Steve. But, you know, this whole idea that potentially finding a community like Survivor.net, how does that help people who are enrolled on clinical trials? Does it help them stay on study longer? Do they get more engaged with their clinicians? Can we measure that? Or is actually the opposite happening, that hearing stories, is that more likely to get people to withdraw from a trial? I mean, I think these are really interesting, novel questions that could be asked.
Yeah, this is also goes along with our white paper too, from this team, what we talked about, how to increase continued engagement in the clinical trials and trial, not only participation, but continuing ongoing efforts. So in one way, there's a lot of noise outside, right? So for people who are looking for information, having their own or detailed information about what they're looking for, and then separating all the white noise in the background, it one way helps them to get the information they need and saves them time and gets most information. There are, exactly as you said, there are some people like, I have enough, I don't want to deal with it. So that definitely, I mean, those are the people that may not sign up. And there are ways to not get involved in this information too. So I think for people who are looking for this kind of information, these platforms, whether it is the SurvivorNet or Reply All, they're very helpful to get them around for people who are going through the journey, who understands them well, in a better way than the rest of the world.
Dr.
And also
Roger,
for the clinical trials.
Sorry, thanks, Chris. Go ahead.
Now, I was saying it also helps for the clinical trials too, because people may have misconceived perceptions about the clinical trials. So this is also like our extraordinary work with our patient advocates and everything being out there on the platforms and increasing the awareness and education, why these clinical trials are being done and what is the purpose and what is the advantage of continuing on the clinical trial. This may not help them, and there is altruism in many people, even if it doesn't help me, if it helps for the future. So those are all the kind of emotions that go through too.
Thank you. Dr. Rao?
Yeah, so I love the commentary so far. The only concern I'd have is long-term value. You know, this is a very select use case, right? You're taking somebody on an individual trial with individual treatment profile. And so how much content can you deliver on that topic long-term? And that goes into the long-term attribution of the benefit of the platform, right? So you may think of somebody who's gonna be a part of this platform. That patient could really be somebody who's gonna get information from the internet long-term, regardless of this platform, right? And so as you get into the first year, the second year off treatment on the study, how much of the length of stay on therapy is really attributable to being participating in the platform? So some of the questions that will come up as you design a project around this.
That's great. I like that. And then I'm sorry, we're running out of time. Steve, you get the last word, but Peggy Zuckerman did want to say something as well.
Yes, as a patient advocate, I think it's critical that people understand that patients don't always read anything that you give them. They simply sign it because they're desperate, or they fail to sign it because there's not a trust built between probably the medical system and the individuals. But I think having an educated patient who feels free to ask questions that might seem dumb when they're trying to say it to a doctor, this kind of website would be very valuable, because patients will ask the midnight questions to one another that they will never ask the doctors. So it is an opportunity to educate the patients and perhaps maintain patients in trials, or just teach them that trials exist. So I'd be interested in following up on what's happening on this site, period.
Thank you so much. Steve, you have the final word.
Thank you for the chance to talk about what we do. We are very interested in featuring the expertise of this kind of group. So I would love to collaborate with anybody who's interested in lightweight ways, like contributing information, and also in the perhaps more heavyweight way of what's the right way to test information on a trial or adherence compliance or accrual. But thank you. Really appreciate the opportunity very much.
So the task for the Digital Engagement Committee, just so you know, is both internal as well as external communications with the public, as well as with our own, the folks that we have that work alongside of us, like this committee, but also everyone who's involved in trials. Separately, if you and Gil Morgan could exchange some communications, that would be great. He is the founder of a truly inspirational crowdsourcing oncology project called OncoAlert that lives on social media. Would be a great person for you to know.
Wonderful.
So thank you very much. And if anybody's interested, again, working on an idea with Stephen, I would welcome that. And again, keep this in mind as we move forward with the agenda. So next, I'm going to turn it over to Frank and Sanjay to talk about our website form that is now live.
Okay. Assume you're seeing my slides now.
Yep.
Okay. So at our last meeting, Dr. Anaya presented a draft questionnaire for soliciting essential information from potential partners, collaborate with on digital health initiatives. We got feedback from a number of you, and we've incorporated that. Thank you for that. And we have put it online as a form on the SWOG website. The form is publicly accessible, but to cut down on spam submissions, the only place it's linked from is the Digital Engagement Committee members resource page. Submissions to the form are automatically emailed to Don and to me, and we can export the full set of submissions as an Excel file and make them available to members as needed. So to reach the form, log in as a member, go to the Member Resources tab, Digital Engagement, menu item, and down on the bottom of that page, the last resource is the Industry Outreach Questionnaire. And so clicking there will take you to the form. That's the URL to share with potential partners. And now I'm going to pass it on to Sanjay.
Yeah, thanks a lot, Frank, for putting it on the website. I think it's will be a great way for companies that approach us to sort of engage in this. So for Reply All Health and for Survivornet, I filled out the form myself, and I think we're going to try to keep these sort of as a repository so that we can look back on them and you know, potentially, you know, gauge people's interests and things of that nature. Also, if there's anything that people kind of, when they're looking at the form, as people start, as other companies fill that out and they get feedback, just let us know, and then we can kind of adjust it as necessary. Because it's just kind of the initial idea of what we thought was important in terms of the overall parts of what information we thought was important. But obviously that's kind of not necessarily 100%, you know, what it might change over time. And it also, if anyone has any ideas about companies that they potentially think that should be kind of, would be great to speak here, but we can reach out to them and then ask them if they're interested in kind of filling out the form and talking to our committee as well.
Great. Any questions for Frank or Sanjay? Again, I would just challenge all of us to bring ideas of companies that may be of interest to SWOG investigators. I'm going to do a shout out to Don Hirschman, who introduced us to Frank Alperin's company. So thank you for that. And again, this is open for everyone to hopefully engage industry. Just be proud of yourselves that SWOG is the only one that has impaneled the Digital Engagement Committee, and I'm super proud of the work that we've been able to do. All right, moving forward, we are going to talk about the social media toolkit. Frank is going to lead this as well with Krishna Gunturu and then Nagla Karim will go last as well. Frank?
Okay, before we jump to that, I just want to take a few seconds to remind us that engagement collaborations we set up with that form may end up with the SWOG Clinical Trials Partnerships Program, SWOG-CTP. So I wanted to announce that we have just launched a website for SWOG-CTP. It is a resource, obviously, for potential partners to learn about SWOG-CTP, how it conducts research, and how they can partner with it, and is at swogctp.org. I urge you to visit and to share the URL with potential partners.
It looks great.
Don, if I could, just Kathy.
Yes.
If I could just give a huge shout out to Frank and Morgan, who's on, who did an enormously intensive effort to get this ready to launch right at the time of this meeting. And if you scroll all the way down to the bottom of the first page of the meeting booklet here, you can get to it quite easily and go through the different tabs. And your name's in there, Don. You can find it later, like where's Waldo? Okay.
Sounds great. And then Kathy, I hope you stay on because we have work to do at the end of this meeting as well.
Well, you didn't give me any assignment,
oh, no.
So I'm not prepared, but I am staying on. So I'll be surprised, I guess.
All right, let's talk toolkits and outreach.
Okay, so the social media toolkit and plain language trial summary have been developed for the S2013 trial, the iCheckIt trial. They've been reviewed by the study team, they've been revised accordingly, and they're now with the CIRB for their review. So what is the social media toolkit? It is a set of patient-directed tweets in plain language, a set of provider-directed tweets, a set of graphics to accompany these tweets, some patient-directed, some provider-directed, and a page of best practices for study team members and champions to consult if they need to when they're disseminating these tweets. So with the social media toolkit, we've submitted to CIRB the plain language summary for this trial, which of course is composed for an audience of patients. And it's essential that the plain language summary be available when the social media toolkit is used, because it provides CIRB approved patient appropriate content we can point patients and their caregivers to with our social media outreach. So I just wanted to say a few words about the process itself. The goal is to have a social media toolkit and plain language summary available at the point of activation for all new trials. Right now, I am working on these, but we have posted a plain language writer position, and we have applications that have been coming in for that position. So soon we'll have a writer dedicated to developing these and related materials. Still discussing with the protocol development team and patient advocates what the best point in the protocol development is to start drafting these. We had a very interesting conversation this morning at the Patient Advocates Committee session about that question. Once they've been drafted, we ask the study team to review. When we have a new recruitment and retention manager on board, we'll ask that person to review as well. And of course, when our dedicated writer is on board, the communications manager will be a reviewer too. We've developed a detailed checklist that reviewers can use to ensure that all the bases are covered. So for 2013, the reviewers provided feedback, we incorporated it, we sent it around for a final review, and I want to thank the iCheckIt study team for their rapid turnaround on this review process. So now the materials are with CIRB. It's possible they'll ask for additional revisions, but eventually we'll get approval, and what then? With the plain language summary, we will share it with the NCI's Cancer Information Service. They're the folks who staff the 1-800-4-CANCER line, and that's one of the sources we direct patients to get their questions answered. We'll also post a PDF of the summary on the CTSU website and on the SWOG website so our sites can access it. And of course, we'll make a version available on the SWOG.org website for our patients as well. We want to get these in the hands of selected patient advocacy groups too, as educational material they can use when advising patients. And the social media toolkit, we will distribute those tweets and the how to use page to the study team and champions. And at the point of trial activation, the @SWOG Twitter account will start posting daily tweets on the study for 2 weeks with the accompanying graphics. That would be a week of patient-directed tweets and then a week of provider-directed tweets. And of course, right now the focus is on Twitter, but I'd like your input on how we extend this to other platforms, other social media platforms. So please send me your feedback and questions, fdesanto@swog.org. And I would also appreciate suggestions on how to best publicize the availability of our plain language summaries to SWOG members at our sites so that they know that they're out there and they can make them available to their patients. So I will turn it over to Krishna.
Thank you very much, Frank. I'd like to thank Frank DeSanto, Dr. Karim, and the rest of the DE team for getting this work beautifully done, written summary of S2013, which is very easy to follow, and also it increases the awareness on multiple platforms, whether through the website, advocacy groups, or through social media, which would be a great addition for the study team who could post these tweets on the social media itself too. So this is a great tool, and thank you again. And I can't wait to start tweeting once the CIRB approval comes.
Okay, maybe we could go from that to just Nagla. This would be a great place for you to just come in with some of the thoughts on the toolkit as it relates to the priorities of the Drug Development Committee.
Great. Thank you so much for giving me this opportunity. Can you see the screen?
Yep.
Do you see the slides? And
yes.
the slideshow? So from the beginning, so basically, of course, it's so important to know about our ongoing clinical trials. I would like to highlight 3 clinical trials during this meeting. First one is S1933, where patients with stage 3 that's locally advanced non-small cell lung cancer, usually they're treated with concurrent chemo radiation. However, a group of them might not have the strongest performance status, borderline performance status, and we do not have a good standard of care for this group of patients. So that's why that trial comes up for those patients with performance status 2, that they could be treated with radiation followed by immunotherapy, which is atezolizumab. So I would say that, this is something that's available. And of course, patients, would benefit, from that. And the PI is Dr. Al-Jumaili. And then the next, any questions there? I know that I'm courtesy of time that, I'm just having those 3 slides. Then S1929, basically it is one way of treating small cell lung cancer is try to personalize treatment. So as we all know, for non-small cell lung cancer, patients are treated, if they have EGFR, they get the pills for EGFR inhibitors, ALK and so on, but we do not have a very good stratification or personalized treatment for small cell lung cancer. So that's why we have this trial to look into patients' small cell lung cancer with SLFN11 positive marker. So those patients, instead of receiving only immunotherapy in the maintenance phase of treatment for small cell, they will have a PARP inhibitor, which is talazoparib, in combination with immunotherapy. And the hypothesis is really to get them to have longer time before their disease progresses. Third, last not least, our DART study, and that is the SWOG 1609. Basically, it is focused on rare tumors. So it is a basket trial of dual anti-CTLA4 and anti-PD-L1 blockade. So that's 2 immunotherapies. Basically, that study is open for rare tumors of the head and neck, small intestine, and pancreatic tumors with rare histologies. So basically, we would like patients with rare tumors in these 3 locations to be aware about that study. And just to finalize, I was talking with one of my study coordinators who was basically just leaving, but telling me a story that she's African-American, and the reason that her husband died of lung cancer, and the reason that patients didn't know about enrolling, especially the African-American community, is basically they didn't have the awareness. They didn't know about the clinical trials. They didn't know that. So I'm just saying that within our medical meetings, which reaches the best research for best care, we really need to reach out to everybody so they are aware about those trials.
Okay, great. And I think what we can do is maybe try to prioritize one of your 3 to develop the social media toolkit, with drug development. We can certainly take these offline. But otherwise, if anybody on the committee has any other ideas for how to help support these particular 3 trials, Gil, I'm looking at you. I think we can look forward to reaching out to Nagla about ideas and potential introductions where she can present this to particularly patient-facing groups and advocacy groups on social media. That would be a start, and I think it would be great. Any questions for Frank, for Krishna, or for Nagla?
Don, I just wanted to echo absolutely 100% on board, and whatever I can help with and whatever OncoAlert can help with, we're right there behind it.
Thank you, Gil. All right, let's move
Don,
forward. Sorry, Kathy, go ahead.
No, this is Krishna, sorry. Just quickly, tomorrow is 2013 kickoff meeting is tomorrow morning at 11 o'clock Central Time. I hope you all can attend. Thank you. Thanks
very much. All right, I have an exciting next presenter group, Cancer Briefs, and an update on that. I'm hoping that this is enthusiastically received as much as I that I have. So I'm handing it over to Jonathan Summers, Eric Stone, and team.
Thank you, Don. Hi, everyone. It's great to see you. We've been working on this CancerResearch project, gosh, it feels like forever now. Just a quick reminder, the project is looking to test this theory. Can media be used to increase the public's awareness of cancer clinical trials? Episode 1, which aired, is a faux news show in the tone of Vice News that looks at immunotherapy, but it's really kind of a love letter to the Hope Foundation. And the call to action at the end is guiding people to the Hope Foundation's donation page. So we had the baseline numbers before it launched, and then after the launch. Episode 2, which is going to be out shortly, we decided to actually put Spanish subtext on it because the episode is about cancer disparities. So if we are trying to engage the Latinx community, we wanted to include that language underneath. So we figured that was well worth the delay. But episode 3, which aired, is seeing, could we increase awareness of one particular trial? It's S1501 in a meta-cinematic kind of commercial that also aired. I would say that was definitely the most fun episode to make. And the call to action for that was guiding people to the plain language S1501 page. I also really want to thank Frank and Morgan for their help with this, as well as Don. You've been a tremendous mentor through all this, and as well as the steering committee. With that said, I think what you guys will most be interested in is learning about the analytics. We'll circle back to production with Eric, but we're very lucky today to have digital marketing expert Rick Andrioli with us, who really launched the marketing campaign. And with that said, Frank, are you able to share the slides, or do you need me to share my screen?
You sent me PDFs, so I assumed you were going to be sharing your screen, but I can share the PDFs.
No,
if you'd
no
like.
problem. I'll do it right now. Okay. And here we go. Rick, when you want the next slide, just say next slide.
Perfect. Thanks, guys. Hi, I'm Rick Andrioli. Yeah, this was a really exciting campaign. And yeah, Jonathan, feel free to jump to the next slide so we get into sort of the nitty-gritty of it. So like Jonathan said, we tested 2 videos, and there were 2 campaigns per video. The reason for that was to test out different audience backgrounds so that we could get as wide a spread as possible and learn as much as we could in a short amount of time. So again, as Jonathan said, the 2 videos linked to 2 different locations, and the ads ran on Facebook and Instagram exclusively. We got a lot of interesting data off of that, which will help us for planning where your audiences are that are highly engaged in these kinds of videos. So the audiences were selected through interest targeting and lookalikes. Interest targeting is where we go for really broad things that might appeal to people. So for example, with Jonathan's help, we were able to create audiences based on people who are interested in cancer research as a topic, or the Dana-Farber Cancer Institute, City of Hope, any of those kinds of things. Basically, if you're not familiar with Facebook, everything you do on the platform or on Instagram, they collect that data. So if you liked a news story from the New York Times that talked about the Dana-Farber Cancer Institute, that data is collected on you. Your age, your gender, you know, how many birthday parties you like. They collect all of that data, and that's how we're able to use Facebook as a marketing tool to find specific people who are really interested in these kinds of things. Now, that's how you cast your wide net, and that's how you get the largest audience in to start. From that, we view the people who have watched these videos the most and create what's called a lookalike audience based off of that. So what we did was, for the videos, when a person watched 95% of the video or more, and that's really big in the Facebook world as a side note, if they watched 95% or more, we then created a lookalike audience based on those people. So if you imagine that this circle of people is the people that watch 95%. Facebook will find people with 90% similarities to them. So based on gender, age, device that they use, like iPhone versus Android, other things that they like within their profile, what movies they watch, those kinds of things. And they can really specifically find more people who are like that initial case group. That gives you an audience of highly engaged people who really want to watch this video or interact with your ad, depending on what your goal is. So just as kind of a broader thing, interest targeting gives you the largest potential audience, but a lookalike audience is more expensive usually, but it finds more engaged viewers. Okay, so not to get too much in the weeds with my nerdy Facebook targeting stuff. So the audiences, yeah, they could react to the video, leave a comment, share them with others, or click through to learn more. We saw a lot of good interaction with clicking through. And again, the goals were to watch the video and encourage clicks to either the Hope Foundation or the S1501 study. So Jonathan, can you flip it, please? Thanks. So this was the first video. And I will explain some of this stuff. It's going to seem like, okay, this is to have 92 people watch 100% doesn't seem like a lot, but I'll explain towards the end that this actually is a very significant large number given the type of video we were showing. So again, the video reached meant that this video showed up on 83,500 some odd people's screens, but they might have just been scrolling past, right? They didn't actually do anything. 52,000 plus people watched at least 3 seconds, and so on. You can see those numbers there. What is important too is that 409 people clicked through, which we see as a good number given the amount of people that started to watch the video. And if you think about how users behave, they watch something, we all have short attention spans now, we click through to get answers quicker. So that's kind of that story there. The fact that the clicks were good, but we were optimizing for video views is a good sign, right? It means that they cared enough about the topic to do the click. You'll also see those 2 ads there were the 2 best performing ads. The only difference is that text at the very top of the page, or the top of the ad, I mean. And the header text that nobody responded to, or audiences didn't respond to as much, was see how doctors are using your body's own immune system to fight cancer. What's interesting about this, if you start getting into the weeds then, is, okay, well, if we're going to target these people, what are they responding to and why? Let's try to break down that analysis there. So Jonathan, the next one. This was for the S1501 campaign. Again, 61,456 people that came on their screens, but 47,566 started to engage with the video. Again, 414 people clicking through, really, really strong. Interesting that more people clicked on an ad with the sad-faced woman, the cancer patient woman, rather than the woman who was smiling at the screen. So that's the one on the lower right side of the screen. And then you can see the 2 sets of copy that worked well, and then the 3 that didn't. We tested more on this one, given the audience size that we could potentially hit. So, and I'm not sure what we draw from those just yet. We need to kind of get more into the weeds to break that down. But that's where we landed on that one. So, and 44 people watched 100% of this video.
Hey, Rick, just quickly, when you say that the people click from the ad to the link, is it when they click that learn more without watching it fully through?
They can click anywhere on the ad. Initially, you're correct. Initially, Facebook set it up where only that learn more button was the clickable thing. Now they've got it where if you just hit it anywhere on that video, it will click through.
Okay.
Yeah.
Thanks.
It might pause the video if you hit, Rick getting nerdy, if you hit right on the video itself, that might pause it, but otherwise anywhere else on the ad does work.
Okay.
Okay, Jonathan. So here, this is a graph showing the boost in traffic when the ads ran. So as you see, there was a big boost during that video play period. To just clarify a couple of things, sessions and page views in this case are the same thing. It can be different if a user goes in, lands on a page, and does other stuff. That would be considered a session, the one time that I am on your website. But because we were directing people to single pages, it's the same. Sessions and page views are the same thing in this case. You'll also notice that the numbers here may not align 100% with the numbers that Facebook is saying. So Facebook says 400 some odd people clicked through. If you add these up, does that add to the same thing? It doesn't always, for various reasons. There's always an acknowledged 10% discrepancy between reporting systems, but also sometimes a user will click a link and then move on, or get bored, or accidentally close it, or it might take too long to load the page, which is why when you guys are looking at your Google Analytics, you look for site load times, because that can, longer the site load, the more likely a user will close the window before the page fully loads. Does that make sense?
Yeah, it does. When did the ad actually run on DHN? The first one?
The first one, please hold.
The one about immunotherapy? Because you're
August 17th.
Yeah. So August 17th?
Yeah. Or maybe, did it hit at midnight, Rick?
No, it launched in the evening, but so after work hours, but it was before midnight. So Facebook can launch it whenever they approve it through.
That's pretty remarkable, I think. The traffic to the website.
I mean,
yeah,
we could also
oh,
sorry, Jonathan, go ahead.
The same, what I find most compelling about this, also is SWOG's one graph underneath it. You know, you could tell for the months leading up, whether it was July to August, you know, that's okay. And then as soon as the campaign launched, it's, you know, pretty telling.
I agree. And these are, remember, to everybody, this was not targeted towards people with breast cancer or people with cancer. This was literally a public health campaign, which we wanted to see what we could get out of it. Just
yeah, that's a great point, Don, that we tried to cast a very large net, as Rick mentioned. And Rick could also kind of get into, if we wanted to get very hyper specific, you know, there are certain analytics with this that for the presentation we didn't include, but we know what states these videos played best in. We know what age groups these videos played best in. And certainly that will be part of the write-up that we do at the end. But just for right now, we didn't include that.
Yeah, we have the best geos, age, gender. We can even get as nerdy as devices that they use to watch the video. They do not, Facebook does not get into race or ethnicity any longer.
All right, is there anything else you want to present, Rick?
Let's see, I don't know. So yeah, keep in mind, these videos were 5 minutes long, 5 minutes. Normally Facebook suggests the video should be 15 seconds or less because of how their users interact. So the fact that we did get people that many people watching and that many people clicking on long videos is very positive from my perspective. It's very positive. And I don't know if you guys care, but you've heard about Facebook in the news. If you do have any kind of concerns, these kinds of ads that we are running are not at all in that world. Facebook is not going to go away anytime soon, so we're going to be able to hit it. We are not using any data to exploit people or sell fake product or anything like that. So there would be no sort of concerns about what this campaign did. One of the things too is, should we test on other platforms? I'm always about testing, but we found in the age groups that it was 45 and older, which means things like TikTok wouldn't resonate. I've not found any kind of success with Twitter ads. Snapchat would be out because they're way too young. So right now, Facebook and even Instagram did not perform well, by the way, you guys, at all. Facebook only. So right now, Facebook's probably your top marketing venue for social media marketing.
I totally agree with this, because it seems that every group of patients actually would benefit or would use one more than another. So I tell you, internationally, Facebook works a lot. There are a lot of Facebook groups, actually, like I noticed not just professionally, but from my family members and things like that who have a specific disease, that's how they connect with. So just to...
Thank you. Opening up to the group for comments.
I'm actually thinking on Twitter, if maybe just by decreasing the actual length of the video to about 2 minutes, I think that it would actually improve the engagement on Twitter.
Yeah, shorter form videos are good. The one thing we didn't test within this was to do a very, very short, say, like you're talking about 2 minute or less or 30-second or less, to link a user over to a specific website. That would be another strategy. But doing a Facebook view ad with a video, it gets you the most exposure because Facebook currently wants users to stay there. They don't want users leaving, so you get the views cheaper.
That's great. So Jonathan and Rick and Eric, I know you're on as well. What are the next steps in terms of this particular project?
Eric, do you want to chime in on the next episode that's coming out?
Yeah, I think it's just getting the episode 2 out. I don't know if we're going to do one that's clean of the subtitles and one that has the subtitles. I'm going to kind of defer to Rick on that in terms of kind of testing that. But that should be happening, within the next couple of days. And then I think it's evaluating the data, trying to figure out, does it make sense to then reconfigure these in any kind of way? Do we go through and try a shorter version of them to kind of test that hypothesis? I think there's a number of different directions we can kind of, take this in terms of the content itself and the fact that it is kind of modular and that you can make those kinds of edits.
I think also, Don, the next step would be once the next episode airs and we have the results, convening with the steering committee to decide what we should do forward, whether it's, write the paper or, as Eric suggested, perhaps retarget some of the advertisements. Yeah,
I mean, I think it's a really interesting idea. I will also just do a shout out to Joe and Morgan. This was, again, a Hope Foundation sponsored project, which was just fantastic. I would like to see this written up for sure. I think it's very novel. This is a demonstration project, and I think the growth that you're seeing, and Rick, in terms of the context as a marketer, seeing these results, I think that would also be a really interesting thing to bring to the medical community. Samantha Wright had a question for you gents on the chat. You mentioned other platforms had too young of an age for these videos. I wonder if they would be more interested in hearing about caregiver info or about maybe taking care of parents or grandparents. What are your thoughts on that in terms of focuses of the video to the caregiving side of things?
I think they absolutely would. However, as we're kind of learning, it needs to be shorter. Their attention span and their grasp has to be within the first 2 seconds. Otherwise, they're gone. What do you think?
Okay, well,
that's kind of...
Yeah, first 3 seconds. And then the bigger question is what's your end goal? So if the end goal, right, like S1501, well, does that resonate with a kid? Do we want them to click through? And by kid, I say anybody 18 to 30, right?
Yeah.
So that's kind of your working backwards. What's your end goal? And then let's see what this is. Like the Hope Foundation Donate, that actually could resonate with with younger people because they're like, oh, I want to be a part of something, right? So could we do a shorter version with her? That would be an interesting test, yes.
All right, so what I would be asked from this group, I need 4 people to join my DE TikTok squad, and we will work on this as an idea with DHN going forward. Nagla, as you are burrowing your 4 eyebrows, I'm hearing that as a yes, you're in.
Yes.
All right, just kidding. But really, I think there's a lot of promise here. I really would love to see this published and getting it out to our community. So yeah, let's get another update at our next meeting. All right, we are slowly running out of time. Thank you very much to all 3 of you. So I'm just gonna go ahead and get to the last parts of our agenda. And if Kathy Albane is still online and can appear, she can chime in on this. So there have been ongoing discussions with SWOG CTP and AstraZeneca about potentially doing digital health projects. And they have a digital health branch within AstraZeneca. And I can honestly say it's been a bit confusing as to how the strategy exactly works, whether it's agnostic of tumor site to focus on a tool for people with cancer at large, or is this a siloed sort of endeavor that it has to be, based in breast cancer, based in gastric cancer, and then you can explore the digital tool. What we've ultimately come down to is an understanding that this is interesting. And I'm really, really happy that Dr. Albane supports this idea going forward. Where we have come up is essentially a solicitation, and this is something I want everyone to take back to their groups, and given what we presented today as well, it's a solicitation for 4 ideas regarding digital health tools that can be vetted with AstraZeneca, CTP leadership, and then members of this committee. And hopefully at the end of that, there will be one that resonates with all stakeholders, and we can launch a digital health project, which we have the green light to do as members of this committee by the executive committee, with funding of the tool and the project with AstraZeneca. So that is the idea. Dr. Albane, do you have any other things to add on that? Oh, you're on mute.
I would agree with, after about perhaps 4 or 5 conference calls, it's starting to be less confusing, especially to someone who doesn't tweet, I hate to say, in this audience, but at any rate, I still sense excitement with it though. Don, share that with you. And they are also charged with coming up with 4 ideas. So the thought is, once Don culls some ideas from this group and they have theirs ready, we'll meet again by call. But trying to come up with things that could be perhaps disease agnostic. It doesn't have to be tied to a trial. It could be. It doesn't have to be an AstraZeneca drug or trial, but we have a platform trial with CTP in the works with AstraZeneca in the breast committee, that might be one of the 4 perhaps that we will do something with. But it could also be any patient you're starting on immunotherapy, or any patient you're starting on drugs that cause neuropathy or whatever. So it could be any type of digital tool. AstraZeneca doesn't make these tools. So that took me a while to understand. I thought they had a whole armamentarium within their company, but this is a group very separate from the ones we're used to working with as clinical investigators. Although there is now a person who also works on the clinical side who's on this group, and I think he's helped to kind of bring it together.
Yeah. So I don't remember, Kathy, did we have a date as to when we were going to deliver these?
Well, I know you were going to use this meeting to, I think you could give us a deadline to your committee here, bless you, Frank. And also, once we have ours together, we could, ping them and say, all right,
we're ready.
Are you guys ready? So figure out what's reasonable for your group.
Yeah, so again, we don't have to vet the ideas here. We're going to go into a couple of ideas or a couple of projects that were either in planning or in progress that could potentially feed into this. But put your caps on and engage the disease site committees as to potential ideas. And I would say this is also a relevant thing for recruitment and retention, as well as our patient advocates committees, whether if they were interested in potentially doing a digital project that would benefit their groups. It could run out of this committee. That's the important point. And so I'm happy to help schedule any calls with any of the teams that you have heard presented, including the ones we have heard from in the past. If you want to just reach out to Frank to start scheduling some things, I'd love to see it. But I think this is a pretty talented group. You're not all on Twitter. None of you are on TikTok, and that's okay. But, you know, I think we can be innovative in this space. All right, any questions?
Don, this is Krishna. Sorry.
Yes.
So let's say if there is an idea with including the digital platform or anything, where would the funding come from if it is coming from this? So I'm just trying to understand.
Yeah, so the concept would come to this group of stakeholders at, I think, you know, AstraZeneca would be at the table, CTP, and then probably myself, if, you know, as long as I didn't have a conflict, you know, from the DE side of things, would vet the idea. We want to come around to one idea that is executable, that is, you know, that is feasible, and that has a good rationale, that is an important endpoint from everyone who's sitting there. If your idea is accepted, AstraZeneca will fund it.
We had talked though, Don, perhaps about having more than one.
Oh yeah,
especially
yeah.
And not just going forward with one.
Yeah.
Maybe one that can be expanded across diseases, and one perhaps that could fit onto this trial that we're already working on with them.
Yeah.
Those were the two.
Yeah, and I think Kathy mentioned it already. The confusion really is, although they have a digital health strategy team, it's not entirely clear on their end how it's all supposed to go and interact. So
John,
a learning experience for all of us, which is great. Yes, Arpit.
Yeah, so I've actually worked with AstraZeneca on this a few years ago. I was the director of innovation for a large health system, and that's been the confusion for many years.
Yeah.
It's like that hasn't improved. But does this kind of, because I may have an idea here that could work for this group, and I can follow up with you and Frank after this this call. Yeah. But does the idea or proposal need to be sponsored by one of the disease teams, or how?
No.
How do you have it?
No, it doesn't. So at our last meeting, I announced that the executive committee had authorized digital engagement to run a protocol that was not dependent on the research sites. So I'm looking for that one golden egg.
No pressure.
So
Don,
really, can we clarify? We're talking like wearable sensors. That's what, or like the sky's the limit. Just go where your mind is taking you in digital space. Okay, thank you.
Correct. Yeah, it could be.
You know, we're not talking about measuring steps or, you know, stuff that, you know, I mean, really, some of these early trials were kind of at a ground level with them. So we're talking about creative, out of the box, almost types of things that would resonate with our patients.
Yeah. So here's speaking now as patient and caregiver. You know, the clinicians see a snapshot of what's happening in a patient's life, and in between visits, there's 2 whole weeks before they're back in the clinic again. They go in, they say, I'm fine, I've been moving around, and yet the information on the Apple Watch shows that they have not moved more than 15 steps a day, which sparks a discussion for the clinical team to use that data to say, you say you're fine, but really are you? And that I'm going to leave that right there, because this is a conversation that's not appropriate for now, but I that's where my head is.
Yeah, well, think about endpoints too, though. What's measurable? We want to keep this scientific. You know, you could think around that concept, and I mean, does it impact survival? Does it impact drug tolerance? I mean, you know, that kind of thing.
Yeah, novel biomarkers even, you know, but certainly quality of life endpoints, like you're saying, you know, what is the correlation between patient-reported activity and what's reported in, you know, a sensor, for example, you know, but we want to be innovative. Arpit, did you have any? Not
just quality of life. I don't want to leave that idea. I mean, there's all kinds of ways this could go.
Correct.
Yeah, I mean, if it's a big enough study that we wrap this in, you know, if we could look at hard endpoints like SAEs, rate of SAE in a placebo control. I mean, that's a huge one for patients.
Correct. Correct. All right. So with our last 9 minutes, why don't we go ahead and hear about some of these updates? Dr. Asmani Sada, you are on.
Yes, sir, I'm on.
Hey,
Hey, Don,
how are you?
I'm doing well.
So
No,
has
this,
there been any movement on the from the myeloma committee with this idea with the Oura ring?
yeah, so, the last time, I had shared an update, we had an early conversation with Aura. Our committee had 3 protocols that were kind of making their way through the approval process with some back and forth with the CTIP and the NCI Myeloma Steering Committee. And there was also concern from Aura. I think, Don, you were on those early calls about, what components would they be funding, et cetera. So we're, now that one of those protocols is about to be activated, we are re-engaging Aura. I have to say that the enthusiasm in general from their end doesn't appear to be the same it was a year ago, probably because, they have, other other partners that they're engaged with. However, we do have a call with Stephen Kent next week. If for some reason, this does not move forward, at my new institution, one of my junior faculty is actually working with our own resources, on wearable devices. And we actually have some bioinformatics folks who are quite interested in doing so. So I was going to potentially have Neha Kordi, join one of the future sessions where, she can present what she's done and how we can potentially utilize any wearable device, get the data that we need, and pitch that as a potential idea. So that's my backup plan. I'm hoping that, the collaboration with Aura kind of moves forward. But I did want to kind of drop that particular snippet. Neha did have one of her mentees present an abstract at ASCO. I think it was, it was a virtual oral presentation on how they've used wearables in newly diagnosed myeloma patients. But the scope of what we're trying to do here is going to be obviously, much bigger than that.
Well, I would encourage you to continue your conversations with Aura and take this forward. This again would be something I would love to see as one of the proposals that go to the AZ CTP collaboration for consideration. And you can let Steve know that Harpreet Rai, their president, has said he has to work with SWOG. And there's a backstory.
I will do that.
I won't get into how I know Harpreet Singh Rai, but I know him.
Okay, awesome. I'm going to
So
jot
let's
this.
Steve Bell. All right, and then Dan Hertz, I just want to get an update on the toxicity app that has been created since our last meeting.
Yeah, so this is a drug interaction screening tool that can be used when patients are enrolling onto clinical trials. And we had designed a prospective quasi-experimental study where we would find ORP staff working at all different sites, and they would not use the tool for a couple months, and then we would get the data on how many patients with drug interactions, and then they would use the tool for a couple months, and then we'd have what the tool effectiveness is in finding and resolving drug interactions in patients enrolling on sort of any SWOG clinical trial. I came to you guys because we were having difficulty finding ORP staff to agree to use the tool and be part of the study. We talked to you guys, and we talked to Don Hirschman, and I talked to the Hope Foundation, and we all sort of decided together that our best chance of getting ORP staff interested in using this is to incentivize them with some sort of financial rewards. So we got Hope to agree to do that. They were very generous in allowing us to reuse some of the funds that had been previously allocated in this way. We got the IRB approval, and we reached back out to the ORP staff that had previously been interested in potentially partnering and working on this with us. And I was surprised to find out that the financial incentives did not increase their interest in actually signing up. I just think this is something that's outside of what they are able to do in terms of signing up for a study and sort of leading it on their own. They don't understand where the data comes from and whether they can use it and all these sorts of things. So I think that we are actually going to change directions, and instead of trying to do this across all SWOG studies with individual ORP, we are going to look for an individual study or maybe 2 to 3 studies that have drug interaction concerns and try to build our tool into those studies. So Don and I had tried to do something for a study that he was developing with flubanserin, and I think we would try to do it there where we have either a period where patients are being enrolled before the tool is activated, and then a period where after it's activated, or we have different sites using the tool or not. So I think we need to regroup and just find a new pathway forward, because going directly through the ORP staff has, for whatever reason, just been not successful, even after trying to incentivize them to participate.
All right, so Dan, I think if you're going to redesign it, again, this is something that we could also take potentially to AstraZeneca as an interest, because I mean, every company, right, and every investigator has a keen interest in drug-drug interactions, and if anything, honestly, to make it easier would be fantastic.
Absolutely.
Okay?
I look forward to
All
working
right,
with you guys.
happy to jump on a call if necessary. And then Jen Klemp, any ideas in terms of your manuscripts that you're helping to head? Jen, if you're trying to talk, you're on mute. Okay. All right. So since we have 3 minutes left, what I'm going to actually ask Jen to consider, and I think it might be a really interesting idea. There is actually no literature in PubMed around social media toolkits in the medical space. So I think this is actually a fairly novel thing. I would wonder if it was too early to discuss toolkits, because we don't have, outcomes information on what it did. But certainly, I think, answering the question of what we could do to help investigators utilize social media would be a really nice piece that builds off of Mina Sedrak's article on what clinical investigators thought about social media, which is basically they love the idea, they see the potential, but they don't want to be the ones to have to do it. So I think a toolkit would be a really nice follow-up article building on some of the data that came out of SWOG. So if anybody would be interested in working on that, I'll chat with Jen Klemp about that as the idea of the next paper that comes out of our group. All right, and we have 2 minutes left. I just want to say shout out to Saad Usmani for his new position at Sloan Kettering. Congratulations. And any other kudos in the last 2 minutes that we should be celebrating? And then just also welcome to all of our new members. And I was kind of, I was a little doubtful we were going to make time, but we've made time. I am officially ending this conference call at.
I had no doubt, just so you know. No doubt.
Did you want to take 30 seconds to share the clinical research resources library?
Yes. Perfect thing to end with. And then our last, this is a new resource page everyone needs to be aware of. So Frank is going to show the page. Carla Laubach at SWOG has created this for us. This is a live resource web page that is on our SWOG website. It goes into everything from the NIH to regulatory and ethical research references. So please take a look at this as you are thinking about trials, designing studies, writing protocols, and running them. This is basically a landing page for all the information of relevance to us investigators. So again, another thing that SWOG is doing to hopefully make our lives easier. And with that, I will close on time at 2:30. Thank you very much for joining, everyone, and have a great week.
Thank you all.
Thanks.
Thank you.
Bye, everyone.
Bye.
Bye.
See you tomorrow, Krishna. Bye, Dan. Bye, Don.